This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is January 2021, and Ryan, we've been at this for 5 years now.
5 of the best years of all of your lives. Except for this past year, let's be honest. 2020, nothing to do with the podcast. 2020 has been pretty bad, but 2021, the year of the vaccine.
External circumstances made 2020 not ideal.
But you've always had us.
Yeah.
You've always had us.
We'd like to think that we helped you get through it.
Yes.
So why don't we start 2021 and hopefully make things better?
Yes, we're going to bring 2021 to a brilliant start by talking about normocellular community-acquired bacterial meningitis in adults in the January issue. One of the articles is titled Normocellular Community-Acquired Bacterial Meningitis in Adults, a nationwide population-based case series. The lead author here is Hannah Holm Vestergaard, and they are at Aalborg University Hospital in Denmark. And actually, to me, normocellular bacterial meningitis is kind of a new term. I've never heard that before, but if you hadn't, like me, basically it's bacterial meningitis with a normal cell count, which, up to 10 to the 6 leukocytes per liter per their definition, basically normocellular, no CSF pleocytosis. But then you also have bacteria. So it's basically right there in the name. It tells you what it is. But anyway, it's a prospective Danish registry, the Danish Study Group of Infections of Brain, in which all cases of bacterial meningitis were reported between 2015 and 2018. In any event, this registry was able to collect 696 cases of community-acquired bacterial meningitis. So they're excluding things, like VP shunts and surgically acquired infections and things like that. Of these 696 cases, 15 of them were this so-called normocellular variant. Then they exclude the mycobacterium and the cryptococcal meningitis because they're such distinct clinical entities, we wouldn't really think of them in the same classification as our traditional bacterial meningitis, leaving 12. So 2% of their overall cohort were these normocellular bacterial meningitis. Of these, 10 were strep pneumoniae, 1 was Neisseria, and 1 was Staphylococcus aureus. It's not really relevant to try and generalize anything from such a small case series, or whether there were concurrent clinical findings or specific risk factors or etc. And even saying that, there wasn't anything that leapt out at me as a universal indicator of when you should be concerned about so-called normocellular bacterial meningitis in a patient with other clinical findings and so on and so forth. So unfortunately, the moral of this little story is simply that it can happen. Luckily, most of these patients were being treated empirically with ceftriaxone, whose half-life is quite long, as would most of you, and would help ameliorate the ill effect of that sort of momentary diagnostic uncertainty in that window until there's a gram stain or a CSF culture that returns and shows you that, the cell count didn't look like meningitis, but apparently it is.
Yeah, I mean, this is tricky. I think the best you can take from this is it exists. It's rare. We're not sure how rare, but it's rare, but it does exist, and it's something you should keep in mind. And you should, at times, if the level of suspicion is really high, continue treatment until cultures come back, and don't actually use your cell count to determine when you stop treatment. It's unclear whether stopping treatment or delaying treatment for a small amount of time had any actual clinical outcomes on these patients. It's too small a sample size to really kind of make much of that data. But the best I can say is this is a real thing. And so, meningitis, which is already difficult enough to diagnose, has just become a little bit harder.
Yeah. But I mean, there's a couple cases where they interrupted therapy because of these sort of, equivocal first results. But most people got ceftriaxone, which gives you 24 hours, until your second dose is due. So luckily, most of our first sort of, our empiric antibiotic choice is a good one in spite of this, relatively apparently concerning finding.
Yeah. So I think the moral of the story is if you really think it's meningitis, keep your antibiotics going until you have culture data.
For all of you who are admitting these patients and managing them on the inpatient service too.
Right. Which is 50% of the podcasting group here. All right, well, why don't we move on? So our next article is Oxygen Therapy and Risk of Infection for Healthcare Workers Caring for Patients with Viral Severe Acute Respiratory Infection, a systematic review and meta-analysis. And the lead author is Alexis Cornier. So this is obviously a topical and very important question with the COVID pandemic that we're all currently dealing with. And many of us have probably been tasked with asking this very question when developing protocols for these patients. And so these authors wanted to assess the available evidence regarding the risk for infection for healthcare workers using different modalities of oxygen therapy to treat patients with severe respiratory infection. They searched the Medline, EMBase, and Cochrane Central Registry for controlled trials from January 1st 2000 to April 1st, 2020. So this is important that this is specifically a time period when COVID wasn't really in the picture. So this is looking at other respiratory infections and mostly excluding COVID just by their time period. Like most meta-analysis, they found over 22,000 citations. 15 studies were eligible for qualitative synthesis, and 16 were included in the meta-analysis. Overall, the quality evidence was fairly low, but what they did find was the highest risk for infection was in intubation, BVM ventilation, and non-invasive ventilation. So those three procedures or therapies had the highest risk of infection for healthcare workers. They noted all other forms of oxygen therapy didn't seem to increase the risk of infection. Now, there's a couple of big caveats here. The first is that there were no observational studies identified by the authors that looked at high flow nasal cannula and the infection rate for that modality, which is one of the major supportive devices we use in severe respiratory infections and in COVID in specific. In addition, the quality of evidence is inconsistent, and while the authors did their best to describe this and control for it, in the end, the evidence is what the evidence is, and so you can only take so much from this data. Despite this, I think the results are fairly reasonable. Intubation, BVM, and non-invasive positive pressure ventilation are all modalities that use positive pressure and thus increase the risk of aerosolization and exposure to the healthcare staff. These are obviously high-risk procedures and high-risk times when managing these patients, but I don't think this data is granular enough to take anything further than these general concepts, meaning we can't really say that we will never use non-invasive positive pressure with these patients, that we should never use BVM when intubating these patients. It's unclear to know how much of a risk that you're really increasing in these situations. And if you're intubating a patient, does adding BVM, if you have to bag a patient to maintain their oxygenation, increase the risk further? It's a little unclear. If you're intubating patients, does adding non-invasive positive pressure to pre-oxygenate a patient, does that increase your risk further? It's unclear. We can't really say much from this data other than these three modalities are probably the highest risk for infection.
Yeah, I mean, it's a case of low quality data in, low quality conclusions out. It's the nice way of saying garbage in, garbage out. But these are imprecise estimates that have face validity. And this is 2020 in a nutshell. And these data are fairly old. And this study is fairly old, even because it's just hitting publication now. This is January 1st through April 1st. More data is emerging to talk about the different ways of transmission and different ways of aerosolizing and concerns about airborne spread. So I think we all know that you have to take appropriate precautions, and sort of the precise estimate of the increased risk is not as important as knowing that we need to take increased precautions. Moving right along, next article that we're going to talk about is emergence of extended spectrum beta lactamase urinary tract infections among hospitalized emergency department patients in the United States. Lead author here is David Talon, and they are at the Ronald Reagan UCLA Medical Center. And still staying on that same sort of infectious disease topic, and since we were just cheerfully praising ceftriaxone's utility as a backstop in cases of meningitis, now we're going to hear some grim news. Enterobacter featuring extended spectrum beta lactamases, one of the implications being that they would be resistant to ceftriaxone. The study population here is a prospective observational cohort at 11 United States university-affiliated hospital emergency departments, part of the so-called Emergency ID Net, which is targeted at sort of identifying and describing emerging infections. These authors enrolled patients 18 years and older who were hospitalized with urinary tract infections, and their primary outcome was the prevalence of ESBL-producing Enterobacter. Out of the 1,600 eligible patients, about 800 were enrolled, and 527 of those had confirmed UTIs with culture growth. 444 of these included Enterobacter, and the prevalence of ESBL-producing types was 17%. So, and in more practical terms, looking at individual antibiotics, 21% were ceftriaxone resistant, 32% were fluoroquinolone resistant, and 14% gentamicin, and 0.3% meropenem. So, a good chunk of UTIs were Enterobacter, and a decent chunk demonstrated resistance, with the big predictor having been prior antibiotics in the last 90 days, although many patients with prior antibiotic treatment just had the same old, regular, sensitive Enterobacter. Some of the facilities included in this study were like specialized transplant centers, so they had specialized patient populations, ones with immunosuppression, who have more frequently getting exotic infections. All were university hospitals, so there may be some skewing towards lack of generalizability to a community center, but the overall gist is we are definitely going to need to start considering upgrading our initial antibiotic coverage in some patients, although this doesn't yet provide us with a lot of particularly useful guidance.
Yeah, I think that's key. I think it also, this is the question of generalizability, and also, should it supplant your local antibacteriogram data, which you would probably say no. And then the other thing is, like, what is the harms of just kind of broadly applying this data to patients who get admitted to the hospital with UTI? It's not outcome data, it's just that it exists. If you have a patient that has a UTI and isn't sick and is not in shock, going broadly really needed, or is, waiting for culture data more beneficial versus, you have a patient who's in septic shock, then certainly starting broadly is recommended by, I think, most of us. So again, I think, like the last paper on the terrifying meningitis, this kind of points out that these exist, but doesn't give us much more guidance.
Yeah, I mean, it's so easy to just go with an algorithm. The IDSA has your algorithms. You're supposed to go down the chart and blah, blah, blah. But this means that you have to actually use your brain, think about which patients have risk factors, which patients are super sick, and which patients might not be improving the way you expect on reasonable outpatient antibiotic if there is a case of such things. It's good to know about so that you can factor it into your medical decision making.
Yeah, I got to say, I think most of these risk factors are kind of already known. And I think if you use the IDSA guidelines, you'd probably actually come up with the same answer as you have here, which is to kind of broaden your coverage in patients that have high risk for multi-drug resistant organisms.
Sure.
All right, let's move on. So our next article is Distance from Freestanding Emergency Departments to Nearby Emergency Care. And the lead author is Rain Freeman. So we're going to kind of beat up on freestanding EDs again, and some would argue this probably deservedly so. But the concept is simple. The utility of a freestanding ED is to support a community that may not have the population size to support a full-scale hospital, but obviously still has acute care needs. And while this is a good idea in theory, it's not how most freestanding IDs are utilized. Most are opened in areas with high payer mixes that already have acute care services available to them. In 2018, the Medicare Payment Advisory Commission recommended a reduction in Medicaid reimbursement rates to freestanding EDs located within 6 miles of the nearest hospital-based ED. So these authors wanted to see how this recommendation could potentially affect freestanding EDs reimbursement rate. The authors used the 2016 National Emergency Department Inventory USA database to identify the location and visit volumes of U.S. freestanding emergency departments. They then plotted the distance of these emergency departments from hospital-based emergency. In 2016, over 5,000 EDs were opened in the United States. Of these, 609 or 11% were freestanding emergency departments. Overall, 38 states had at least one freestanding emergency department. Only 9 freestanding EDs, or 1.4%, were located in rural areas. Of all the 609 freestanding EDs, 11 were located in areas with a median household income less than $43,000. So again, like we said, most of these were located in busy areas with a high payer mix. Overall, this is a great statistic. 57% of the freestanding EDs were located in Texas. I think we've covered this before. Because of how Texas law is structured, it's incredibly easy and incredibly profitable to open up a freestanding ED, and so that's where most of them are. And in fact, it dwarfs the states with the next highest number of them, which included 6% in Ohio, 6% in Colorado, and 5% in Florida. The authors found that most freestanding EDs, 76%, were within 6 miles of a hospital-based ED. And, it's actually a fairly interesting article that you can dive into the details that I don't think is relevant here on this review. But I think these findings are in line with previous studies that we've reviewed on this podcast. And that is, the current financial incentive for freestanding emergency departments is to build them in high population areas with high payer mix and high reimbursement rates. Changing these incentives might change the geographic locations of these emergency departments, but that, of course, is not proven by this data, and we'd have to see.
Yeah, so you can obviously see in Texas, you have this incentive to open freestanding emergency departments. It's a capitalist, profit-driven incentive. If you just take away that incentive, you don't get a redistribution of freestanding EDs. You just get no freestanding EDs, like the other states where there are very few, or most of them are affiliated with hospitals. Hospitals increasing their capture network, trying to capture a greater market share of their specific community and funnel it into their major academic or tertiary referral center. Those are the sort of the incentives that exist in those other states. So you're not going to get people putting freestanding EDs out there to serve a population that doesn't have access to acute care services, because all you're doing is just reducing the incentives. It's a problem that our market forces are just not well constructed to solve, the problem of people not having good access to acute care services. And Texas is a great example of what happens when the incentives exist to the contrary.
Yeah, it's funny that we keep making the same mistake, that we have a capitalist and profit-driven healthcare system, and somehow we think that the nonprofit healthcare needs are going to govern how the system works, when clearly, time and time again, it does not.
And I guess we'll just keep on getting freestanding emergency department articles saying the same thing until I don't know. But they do close, certainly they do close if people can make these close, which isn't a great solution either. I mean, our goal is not to drive physicians out of business or physicians and business partners out of business and entrepreneurs out of business. Freestanding emergency departments are an innovation in care delivery. We shouldn't be stomping on them. But the way that they've been, they're 57% of them are in Texas, and most of them are just providing redundant access. That this clearly is a failed implementation.
Right. The idea is to fill a need that some communities don't have, but because of the way they are incentivized to make money, they're not fulfilling that need at all.
Yeah. Hey, we just have to find a way of fixing the system without punishing the people who, in good faith, are just following the rules and starting a center that provides additional medical care within the bounds of the legally available climate. We should be punishing those people in our solution. We'll see what happens. All right, moving on. The 3-year effect of Medicaid expansion on emergency department visits and admissions. Our lead author here is Ali Mogateri, and they are at the George Washington University. And one of the either glorious or inglorious things the Affordable Care Act did was provide an incentive for expanding Medicaid. Some states did, some states did not. So we get this non-randomized, quote-unquote, natural experiment. And this paper looks at this so-called natural experiment by looking at changes in the payer mix of ED visits across 527 emergency departments in 28 states, equally divided between 14 expansion states and 14 non-expansion states, and looking at a study period between 2013 and 2016. Sort of when the Affordable Care Act and Medicaid expansion were getting rolled out and taking root. As you might guess, not much changed in the non-expansion states. Any changes in payer type, whether Medicaid, uninsured, private, or Medicare, were on the orders of a fraction of a percent or a small percent, and not specifically related to related to overall trends in the United States, the greater trends in care. In the expansion states, what happened was, well, sort of what you would expect: a basically equal decrease in the uninsured, matched by an increase in Medicaid. Uninsured went down, Medicaid went up in the emergency departments of the expansion states in basically the same proportions. I say what you expect somewhat facetiously because we didn't really know what to expect. There were actually dueling opinions on the expansion regarding whether it would unburden EDs or, like in Oregon, drive greater visits to EDs because of patients feeling empowered to present for care following the receipt of insurance. So the authors point back to Massachusetts, the original Medicaid sort of expansion state, as their best prior example, in which essentially what happens is this fringe of the upper crust, if you must, of Medicaid, of uninsured, acquires Medicaid, and they're a healthier, with fewer social determinants of care afflicting them. And they don't actually overutilize the services. They just have gained services, as opposed to the Oregon example, where it was a lottery, where they gave basically random people Medicaid insurance. So it could have been, it got the whole scope of Medicaid eligible people, also all the uninsured. So you can basically, what they see is something more reflective of the Massachusetts experience versus the Oregon experience. And that makes it the one-for-one wash. That's their theory about why they observe what they observe. And I think that's probably about as reasonable explanation as any. So what's going to happen if you expand Medicaid in all the other non-Medicaid states? Probably the same thing. So it's not going to overwhelm the system, but it's also decreasing the overall number of ED visits either.
Yeah, I mean, I think at this point we shouldn't be surprised. I can't even count what number of study this is that, when you give people more healthcare, it doesn't really change the amount of visits to the ED, and that's probably because what determines visits to the ED is far more complicated than simply giving someone healthcare. And as long as we exist in a profit-driven system where there's different incentives on expanding family practice health and community health, it's gonna be very difficult to decrease the amount of visits that come to the emergency department, independent of the healthcare payer mix. I don't think that's to say that this isn't important. I think from a patient perspective and a personal perspective, it's very meaningful to have your healthcare paid for. So, we often look at this expanding healthcare didn't affect outcomes. And yes, if you simply look at outcomes as the amount of patients that come to the ED, it didn't, but it certainly did have an effect on a personal level.
That's the key. There's so many studies looking at this expansion through such a narrow lens that you can almost show a positive effect or no effect or an ill effect depending on what lens you choose. But when you actually ask the patients and try and measure outcomes, well, it's that's a different patient oriented outcome that very few people are looking at. And then where the time frame for follow up has really only been a few years. So if we're looking at long term, disease oriented outcomes, then we haven't really seen those effects yet.
I think the take home message from this and all the other studies we've looked at doing the same question is, if you want to reduce the burden on emergency departments, your treatment has to be more than simply giving people insurance. There has to be a broader, more holistic look at our healthcare system, and providing people with proper primary care is probably one of the bigger parts.
Exactly.
Not opening more freestanding EDs in Texas.
As long as they take Medicaid.
I don't imagine many of them do. In fact, I think we've looked at that before. All right, well, let's move on. The effect of the consent process on patient satisfaction with pain management, a randomized controlled trial. And lead author is Sapphire Valentine. So, studying therapeutic interventions that target patients in pain is difficult, as there are many aspects of the methodology that can influence patients' interpretation of the reported pain. One such question is getting informed consent in the emergency department at enrollment versus getting informed consent later on follow-up. How does that affect patients' interpretation of their treatment and their pain? So these authors conducted a randomized controlled trial attempting to answer that question. They enrolled a convenient samples of patients from 8 a.m. to 8 p.m. on weekdays who were 18 years or older and had moderate or severe pain, which is defined as a triage pain score of 4 or greater. Patients were then randomly assigned to provide consent in the emergency department or at the beginning of the follow-up telephone call. They enrolled a total of 825 patients. 414 randomized consents in the ED and 411 during follow-up. 137 of the patients could not be contacted and were deemed lost to follow-up. So outcome data was available for about 655 patients in total. The results essentially are that patients who provide consent at follow-up are significantly less likely to be very satisfied with their pain management than those who provided consent in the emergency department. It was 56% of the patients in the emergency department and 44.5% of the patients at phone follow-up were very satisfied. So it's an interesting study and interesting results. The outcomes do suggest that obtaining consent in the emergency department will lead to a better or a more optimistic interpretation of the patient's treatment than if you achieve consented follow-up. It really doesn't change how you clinically manage patients, but certainly it's something to consider when reviewing and planning studies on the treatment of pain in the emergency.
Yeah, it's just a very interesting look at it's very important for people who are planning studies, but it's just such an interesting look at how people perceive the way their care is managed when they know they're in a study, and their perceptions, and then how it influences their recall and so on and so forth about their satisfaction with their patient, their visit. There's so much going on in patients' minds, and the actual process of performing research impacts the results as much as potentially even the research intervention itself. So when you think about studies that don't have a control group and don't have a good comparison group, but people know they're in a study, they're just providing a sort of a single arm study. This is the effect that you get. You have these unmeasurable or unpredictable effects of the actual just being in the research study.
Yeah, fascinating. Doesn't help us clinically, but certainly when we're reviewing data on pain management, I think this is definitely something we can take into account.
Just what we needed. More levels of complexity to make us more skeptical of the findings of what we've read. All right, getting into a couple brief research reports that were in this past issue. This one is called National Institutes of Health Support for Clinical Emergency Care Research, 2015 to 2018. Our lead author is Jeremy Brown, and they're at the National Institute of Neurological Disorders and Stroke. And like I said, brief report regarding the state of funding for research in emergency care, which has gone from dismal to poor to, well, let's not spoil it ahead of ourselves. So back in 2011, there were a grand total of 63 research submissions in emergency care. In 2014, there were 163. Now, in the scope of this study, 2015 to 2018, started at 373 in 2015 and has risen to 434 by 2018. 24% of these were funded to the tune of $161.9 million of new research funding, including, by the end of the study period, 32 new R01s in 2018. So this is all it's all trending positively in the right direction. So overall, good news, but not well distributed good news. The success rate for new investigators, which if you're trying to create a whole body of researchers and academics for emergency care, you need new researchers to get funded. Well, they contributed 40% of these submissions, and their success rate was 15%. The success rate for the 60% of submissions from established investigators was 34%. So they were we're funding, but we're funding the same people and not really adding to the volume of people, new investigators in emergency medicine, at the rate that we would like. So there are definitely efforts in emergency medicine and good new mentors and new mentorship programs to develop new investigators, but it's not clear from these data how successful they are getting at stuck. There are definitely efforts in emergency medicine to mentor and develop new investigators, but it's not yet clear from these data how successful they are at getting stuck in. Finally, the last item covered here is, how does emergency medicine compare to other specialties? Well, pediatrics submits at a rate twice as frequently as emergency medicine. Psychiatry submits research proposals at a rate 6 times that of emergency medicine, and neurology 7 times the rate. This article doesn't report the success rate of those specialties for comparison, but you can imagine if it's anything similar, those specialties are garnering far more research dollars than emergency medicine. So, emergency medicine just doesn't seem to manufacture researchers at the same rate as other specialties. These data don't identify the specific reasons because it doesn't describe those, but clearly, someone should do some research into it.
Yeah, I think this will be the kind of take-home message for both our brief research reports is we're not doing as good as we should, and this data doesn't really give us any insight into why. I think on that note, we can move on to our next brief research report, which is Sex Distribution of Editorial Board Members Among Emergency Medicine Journals, and lead author is Michael Gottlieb. And so there's lots of data suggesting that there are significant sex disparities in the makeup of editorial boards in journals across the medical specialty. And these authors wanted to look specifically at emergency medicine journals to examine the sex distribution. So what they did is they conducted a cross-sectional survey of emergency medicine journals, which they identified using the Cymago journal and country rank, and they obtained the sex and editorial boards by using publicly available data on the journal's website. They assigned sex according to the knowledge of members or his or her online faculty profile, and in cases that were less than clear, they used a genderizer program, which I think we've discussed in previous episodes, which assigns a potential on the gender of person in question.
Genderize.io, in case you're curious, if you want to go play with it yourself.
Overall, they identified 36 journals that met their inclusion criteria. 46 total editors-in-chief. Out of 46 total editors-in-chief, only 4, or 8.7%, were women. Of the 4,407 total editorial board members, only 16.3% were women. And this ranged from 0% up to about 33% per journal. They found a slightly increased rate at 28.6% in the social media editors were women. They found a slightly higher percent at 28.6% when they looked at the social media editors, and an even higher rate, 70%, when they look at resident or fellow editors. So all in all, this is not great. I mean, this paints a picture that we're doing just as poorly as the rest of medicine as far as having a diverse group on our editorial boards. Unfortunately, just like the last study, this data, while it can say that we're not doing well, it doesn't really give us any answers to why these discrepancies are present or discuss any ways that we can go about correcting them.
But of course, the first step is literally just describing that you have a problem. And so this article and articles we've covered before talk about this discrepancy and the disparities, in gender in emergency medicine. And we focused on Annals of Emergency Medicine specifically as well. So recognizing there's a problem and putting together a task force, which I know there is on our editorial board, to actually put together a task force to try and recruit additional female members and decrease the amount of gender disparity. I know this is an effort that is happening. So hopefully this is happening at other journals as well, looking at the root causes of their discrepancies and proactively addressing them.
Yeah, and we've looked at this in Annals, now we've looked at this broadly, but we've also looked at it in, the rate that women versus men get awards in emergency medicine, have mentorship in emergency medicine, so on and so forth. So this is obviously a broad-ranging problem that needs a broad-ranging answer. All right. Well, I think that wraps us up for another month. So until next month, any questions, comments, and concerns, we can be reached at annalsaudio@acep.org. Otherwise, this was Ryan Rudecki and Rory Speaker, and this was the Annals of Emergency Medicine.